Hey guys, so we are having midterms tonight, and in the midterm class, if we don't have a lecture online, we are going to have to do 2 or 3 chapters at once at the end, and I didn't want us to do that. So today I am going to go ahead and do a lecture, put it online. That way next week you will be in the same order. We're still going the same way. So this week is the respiratory chapter. I would have rather done this one in class, but time just did not adhere for it. Reasoning being is respiratory is a very important system with a lot of different words, as well as it's a very long lecture. So keep in mind this lecture is a little bit long. You need to be ready for it. All the homework for respiratory will be due next week on the Wednesday as the calendar says. Okay. So chapter 7, the respiratory system. Make sure you follow around along with the PowerPoints. It might help out quite a bit more than if you don't. Okay, so today we're starting with respiratory. Your first slide is always your keyword parts. So we'll go over all of these as we go. Okay. So starting with the functions of the respiratory system. The respiratory system brings oxygen into the body. It expels waste products and it produces air flow through the larynx for the speech. If you do not have the proper amount of oxygen, you are considered hypoxic or hypoxia, which is a condition of having deficit or oxygen levels in the body tissues and organs. Hypoxemia is a condition of low oxygen levels in the blood. For those of you that are CPR trained or are going to be, you're going to find that the brain cannot go without oxygen for a very long time. And that also includes, it has to have a sufficient amount of oxygen. If we don't have the proper amount, it will start to damage the brain. With the expelling of the waste products, we have carbon dioxide and water that's in this system. Carbon dioxide is expelled while we're inhaling oxygen. So if you're unable to expel all that CO2, then you're going to have a condition called hypercapnia, which is too much carbon dioxide in the blood. This can be considered just the same as not having enough oxygen as it is. Producing airflow through the larynx of this for speech. So in goes the blood or the air. This is what in and out is what makes us have speech with our larynx, and we'll learn more about that as we go. Structures of the respiratory system. So your upper respiratory tract consists of the nose, the mouth, the pharynx, the epiglottis, the larynx, and the trachea. Okay, and then your lower respiratory tract is the bronchial tree and lungs, which are located within that thoracic cavity, okay, also known as the thorax, which protects these structures. So it protects the lungs, which the thorax also helps with the heart and stuff from the cardiovascular system. These structures are known as your airway, okay? So first screen, you have naso and rhino. These are all nose. Your nose is part of your air passage, okay? It does have these olfactory receptors in our air passage. This is our sense of smell. If you have a loss of smell, it's an anosmia, okay? Or anosmia, okay? Filtration of debris by nasal cilia. So cilia are those hairs that are in the nostril, okay, in the nostrils, and they kind of go all the way back. This keeps from some of that pollen and stuff getting in. Obviously, it's not 100% proof, but it keeps the majority of things out that could cause us a great deal of issues. And then part of our nose is the mucus, which is a slippery secretion produced to protect and lubricate the tissues of the nasal passage, okay? Mucus is also a membrane that lines the respiratory tract. It's along with the digestive, reproductive, and urinary tract. So if you think about it, we have snot in all our different spots, okay? Which is all secreted by our mucous membranes. So air goes into the nostrils through the nasal cavity, and it's located into the interior part of the nose. Next, we have the sinus. So you have your sino, sinu, and sinuso. Sinus has 4 sinus cavities named after facial bones. So you have your maxillary, your ethmoid, your frontal, and your sphygmoid. The frontal and the sphygmoid have 15 to 20 small pockets associated with them. Okay. The sinuses are air-filled cavities within a bone that is lined with a mucous membrane. The purpose of these sinus cavities, one is to make the bones lighter in the skull. Otherwise, your head would be extremely heavy with all the bones we have in there. Okay. Produce sound for your voice. Okay. And produce mucus. So that's what the nasal cavities are all combining. Okay. Then you go on to your pharynx, so pharyngo. This is also an air passage, and it's commonly known as the throat. Okay, there are 3 divisions to the throat. There's the nasopharynx, which is posterior to the nasal cavity. You have your oropharynx, which is visible when looking in the mouth, and your laryngopharynx, which contains openings of the esophagus and trachea. As we were talking about the laryngopharynx, we bring up laryngo, which is your larynx. This is where your speech comes from. It's also known as the voice box because they have some vocal cords, and what the vocal cords do is they close during speech so the sound is produced when air is expelled from the lungs, vibrating those cords. And then during breathing, they are separated so the air can pass. You have 9 different cartilages in this area, with the thyroid cartilage being the largest. We call it, being the largest, it creates the Adam's apple, as we all know, where men have one, women tend not to. Okay. Laryngopharynx, that's the combination of your throat and your voice box. Okay, so this is where air, food, fluids go through the mouth and the nose and head toward the openings of the esophagus or trachea, where the air will enter the trachea and the food and fluids go towards the esophagus. Okay, and what we're going to learn next is there's a little flap that kind of goes over the trachea, so when the food and fluids go in, it doesn't go into your trachea, which we all joke when we choke how it went down the wrong tube. So it doesn't necessarily go the wrong tube, but it could irritate the nerve of the epiglottis. So as you see, epiglotto is the epiglottis. This is the covering. It covers the laryngopharynx to protect the airway. By this structure, which is located at the base of the tongue, it swings downward and closes off the laryngopharynx so that the food does not enter the trachea and the lungs. Okay. Next, you have tracheae and tracheo. These are the trachea. This is an air passage to the bronchi. Okay, commonly known as the windpipe, which is divided at the carnea into primary bronchi. And it's located in front of the esophagus. All right, so you see it's a different tube for the air to go down versus the food. So this is why it came up with that old saying, the wrong tube. Your bronchi or bronchio, that's your bronchus. You have a right and left. It's divided into primary, then segmental, then terminal bronchi. Okay. Your air passage goes to the bronchioles where air is exchanged from the oxygen and the carbon dioxide. At the end of the bronchioles, you have your alveolus, okay, or alveolus. These are small sacs. There are about 300 million in your lungs. The alveoli or air sacs are found at each end of each bronchiole. The exchange of gases occurs between the alveoli and the capillaries. Okay. Pneumonio, and pulmono mean lung or air. These word roots are the organ of respiration. Okay, that's your lungs. Pulmonary means relating to or affecting lungs, always, okay? So you're at the lung area and we are starting to talk about parts of the lung, and these are lobes. So you have the LOBI or the LOBO, which is lobe. Each lung is divided into lobes. The left has 2 lobes, the superior and the inferior, while the right has 3, superior, middle, inferior. The left lobe is smaller due to the space restrictions of the heart being on that side. Okay. Then you have your mediastinum. Okay. This is the space between the lungs, which contains the heart, thymus, distal esophagus, trachea, and greater vessels. Okay. Then you have your chest, the thora or thoracod, THORAO or THORACO. Okay. Part of the body between the neck and the abdomen, a cavity containing the heart and the lungs. Sorry, guys. Then last you have your diaphragmat. So it's DIAPHRAGMATO, or your phreno, FHRENO. The reason the diaphragm is known as FHRENO is because of the nerve that actually alters it. So the diaphragm is controlled by the phrenic, PHRENIC nerve. It contracts and moves the diaphragm to assist in inspiration. The diaphragm is also the muscle that separates the chest and the abdomen. So you know where your chest starts and where your ends and your abdomen starts. Okay. Next, the PowerPoints go into your specialists. So they hit on 3 major specialists. The first one is otolaryngologist. This is a specialist in diagnosing and treating diseases and disorders of ears, nose, and throat. They also call it an otorhinolaryngologist, or we call it for short an ENT, ear, nose, and throat doctor. Okay. Pulmonologist is your next one. Okay, this specializes in diagnosing and treating diseases and disorders of the lungs. All right, so we see that ologist, as we've learned in the past, is the specialist, and the pulmo is your word root for pulmonary. Types of specialists, they also have something that's very crucial, and you see these in the hospitals all the time, are respiratory therapists. These are the people that they're more respiratory techs that we see than the actual therapists themselves. These provide treatment to ease or correct breathing problems. These are people that you see in the hospitals that do breathing treatments. They do the suctioning that help with people who are being placed on ventilators and so forth. Okay. Next, we're going to go to the pathology of respiratory system. Now, the pathology of respiratory system is kind of long. I've added to some of the PowerPoints too, so please pay attention, okay? Everything I've got is pretty much out of your book. So first they started out in the PowerPoint with the chronic obstructive pulmonary disease. This is known as COPD, okay? Most people call it by the abbreviation versus the whole name. This is a group of respiratory conditions characterized by chronic airflow limitations. The asthma and emphysema are considered COPD conditions, okay? However, you're hearing more and more that if it's COPD, we call it COPD. If it's asthma, we call it asthma, but realistically, they're all part of the same group. So being that asthma is one of the biggest things, I wanted us to hit on it. Okay, asthma is a chronic inflammation disease of the bronchial tubes. It's often triggered by allergens. Okay, you hear things like asthma attack. These are episodes of severe breathing difficulty and coughing and wheezing. This area we have a lot of asthma, partly because of the steel mills, and it does go as far as pretty much Crown Point and further that the steel mills actually reach us. Okay, These are treated with bronchodilators and metered dose inhalers. Bronchodilators, are inhaled meds that relax and expand the bronchial passages. You have two types of bronchial dilators. You have your strong acting, which are your rescue meds like the inhalers, and then you have your long acting daily control of condition. This can come in different ways. It can come in pill form. Most of them come in a different inhaler form, but this is not something you take if there's an emergency. Okay, then you have something called a nebulizer. Before they only were in the hospitals, and then they got kind of smart and started making small compact versions of this. So these are electronic devices that pumps air or oxygen through a liquid made to turn into mist when it is inhaled. Okay, these nebulizers are absolutely wonderful. They keep a lot of kids and adults from coming into the hospital a lot. If you have COPD, you get pretty used to having to do this on a regular basis. Okay. So the next thing we're going to go into is bronchiectasis. This is a chronic dilation of the bronchioles in the bronchi. Okay. They also this is kind of different than bronchitis. Bronchitis is not a chronic thing, although they do have, I apologize, I must sneeze. They do have a chronic bronchitis, but it's different in nature. Bronchitis tends to stay in the upper bronchi, where the bronchiectasis tends to go lower into the bronchioles. Okay, so that is the lower. That's part of the lower respiratory infection systems. The pathology of the upper respiratory systems are things like rhinitis. Okay, that's, from the itis, that's a form of inflammation. Okay, so it's an allergic reaction to airborne allergens that cause an increased flow of mucus that's termed allergic rhinitis. This is commonly known as an allergy. Okay, then you have epistaxis. These are your bleeding from the nose people, or nosebleeds. Although we look at it from a standpoint that it's just a nosebleed, it can be involving depending on a patient's medical history. For instance, if they're on blood thinners, they might actually clot. Big clots will come out of their nose. We sometimes have to give a medication that actually has cocaine in it to constrict the vessels in their nose to stop them from bleeding. It seems that those who have one or two nosebleeds tend to have more. Some chronically have them. You will find also in older people that the reason they have them is because we get old and we become nose pickers. And a simple scratch in the nose for someone who is on a blood thinner can be very devastating. Okay, they also come from dry air. So in the winter, when we turn on our heat, if we do not have humidifier or some form of humidified air going through the house, it can get very dry and you can get a nosebleed. Okay. Next, you have the inflammation in your sinuses. This is sinusitis. Okay. Then you have your rhinorrhea. This is an excessive flow of mucus from the nose. These are your little runny noses. Your little kids have a runny nose. It actually has a definition, and it's rhinorrhea. So the inflammation of the nose and throat is called the nasopharyngitis, or it can be, let me see how I remember how to say it, orinopharyngitis. Okay. These are your upper respiratory infections and your common colds. There is another name for it. It is coryza, C-O-R-Y-Z-A. Okay. I'm going to get away from the PowerPoint for a few minutes and talk about two illnesses I think that are very important to talk about. One is the influenza. We call it the flu. Okay. Now keep in mind, doctors call a lot of things the flu, but influenza A and B are the true flu. They're acute, highly contagious viral infections. The symptoms occur that are respiratory inflammation, fevers, chills, and generalized body aches. It's spread by respiratory droplets. It occurs mostly during the cold months, and some strains can be prevented by the annual immunization. However, there are many strands. So, for healthy people, we don't always suggest the flu shot because there are so many strands, you can still end up with the flu. For the older people, there is, I guess, a formula that they do to decide which strand's possibly going to be the worst in this area, and that's the one they immunize you against. Some people will say they feel that the flu shots get them sick. I do find that you are a little weaker after it, and if you read the side effects of all your immunization forms when you sign them, they do talk about how you can run low-grade fevers, you can have body aches, and so forth else. Those are, you are putting a virus in your body where the shot is not as much as a live virus as the nasal. They have a nasal spray that is a live virus, but it is a concoction of the virus. Then you have pertussis. Pertussis is a disease known as whooping cough. Okay, dog owners know what this is. You guys all have heard of this if you have a dog, because they vaccinate people from this, or dogs from this, and who are boarded. This is a contagious bacterial infection of the upper respiratory system. You get what's called a paroxysmal cough, and what that means is sudden or spasmo-like. It's followed by breathless or noisy inspiration. You can be vaccinated against this with a DPT, or DTaP as we call it. That's your diphtheria, pertussis, and your tetanus. So if you go to the, say you go to the ER because you cut your finger and you haven't had a tetanus shot in a while, you can ask them to give you the DPT test, and it actually will get you vaccinated for the pertussis for a while as well. The reason this one is so important is it's not necessarily for us as adults, but for the children, babies in general. We treated it, our bodies treat it as a small cold. It's not something we usually get admitted for or so forth, but to a baby under the age of 1, pertussis can be life-threatening. If they get it, it's very hard for them to fight it. I see most of these patients ending up in ICUs, in children ICUs. This is something, if you're a new mother or father, you definitely want to be vaccinated from, so you don't give to your child. Okay. We're going to go into the pathology of pharynx and larynx. You have your pharyngitis, which is the inflammation of the pharynx. We also call this a sore throat. Okay, this is not strep, this is a sore throat. Pharyngoragia, this is bleeding from the pharynx. Then you have your pharyngoria, or your pharyngoria. This is nasty discharge from the mucus from the pharynx. Laryngoplasia, this is paralyzing of the larynx. Okay, so paralysis. Then you have your laryngospasm. These are sudden spasmodic closure of the larynx. Keep in mind this is involuntary closure. Okay. You have aphonia, as you see in the word building, loss of ability to produce normal speech sounds. You have dysphonia, which is an impairment of the voice. This is usually includes your hoarseness or your loss of voice, like cracking, cracking like in puberty. This is what dysphonia, that's what they call it, is dysphonia. Laryngitis, or laryngitis, is the inflammation of that larynx. This is usually when you lose your voice, okay? Then we go to the trachea and bronchi. The first word building is tracheitis. We know itis, over and over we've said it, it's inflammation. Trachea is the trachea. Tracheoragia is bleeding from the trachea, okay? You see this more in those who have what we're going to learn later, those tracheotomies, those little holes in their neck that they breathe out of. You have your bronchitis, inflammation of your bronchial walls. The next word building is bronchoragia, bleeding from the bronchi. Okay. And last out of this group, you have bronchorrhea, excessive drainage of mucus from the bronchi, often caused by chronic bronchitis and asthma. Okay. Next, we're going to go into the pathology of the pleural cavity. The pleural cavity, as we learned earlier, kind of encases the lungs. Okay, you have your one that's well known as pleurisy. I don't know too many people who've had it, but when people do have it, the inflammation of that pleura, it causes a great deal of pain. And the reason is because you have this serious fluid between the parietal and the visceral pleuras, which are the layers of the lungs, the lung covering. And if it is inflamed and you have a little bit of that serious fluid, it's more or less tissue rubbing on tissue. Okay, it causes what we call pleurorrhea. It's a sharp pain that occurs when the inflamed membranes rub against each other with each inhalation. So this pleurisy causing this pleurorrhea, it is extremely painful every time you take a breath. And as much as you can't hold your breath, that means they're constantly in pain. This pleurisy can be caused by trauma. It can be caused by tuberculosis, which we'll learn later, connective tissue disorders, which we've learned in the past with the autoimmune section, and any infections. Okay. Pleuralgia, this is a pain in the pleura or in the side. Okay, so this would be pain kind of in this area, the chest in a sense. Then you have a pneumothorax. This is life-threatening. This is emergency. This is what we get chest tubes for. Okay, this is accumulation of air or gas in the pleural space, causing the lung to collapse. So the way people breathe when we know they have it is they go to take a breath and only one side can move because it's so weighted down. Then you have your pleural, okay? Pleural infusion is how we usually know it. This is an escape of fluid from the vessels into the tissues of the cavity. So a pleural infusion involving the chest cavity prevents the lungs from fully expanding, okay? Then we talk about pyothorax. This is disgusting, and it's an accumulation of pus in the pleural cavity. We also call it an empyema, which describes pus in other parts of the body. But if you have empyema of the lungs, you literally have pus surrounding your lungs and pressing on it. These definitely get a chest tube as well so that we can drain all that pus-filled fluid out of there. Okay. Hemoptysis, this is an accumulation. You know what? I don't think I have the right word here. Hemoptysis is spitting of blood and blood-stained sputum. Accumulation of blood. I don't remember what the accumulation is, guys. Oh, you know what? Accumulation should be a hemothorax. Okay, this is, as I talked before about that air or fluid with a pneumothorax around the space. A hemothorax is an accumulation of the blood in that cavity as well. So with pneumothoraxes, empemas or pyothoraxes, and let me tell you, usually hear it as an empyema, or hemothorax, we have to place chest tubes. If not, there's a good chance that they will have respiratory issues, possibly can what we call suffocate from this fluid or blood. So we place in the chest tubes to remove it. Paramedics with these will do what's called a needle decompression. If they stick a needle kind of in the upper part of their chest, the kind of the top of the lung, to reinflate the lung, which we call a collapsed lung to be atelectasis, which we'll learn shortly. So they have to needle decompress to get that lung to reinflate. Okay. As I said, hemoptysis is spitting up of blood or blood-stained sputum. Hemoptysis is one of those things that when we first hear it in any medical setting, we get concerned of tuberculosis. That is just one of the signs. The downfall with hemoptysis is that just because you're spitting up blood doesn't mean it's coming from the lungs. It can be coming from the digestive tract, but you have to consider that it may be coming from the lungs as well. Okay, so pathology of the lungs. Remember what we said, pulmonary. Pulmonary means lungs. It's pertaining to the lungs. So if you have something called pulmonary edema, this is an accumulation of a fluid in the lung tissues. Okay, so this is swelling. Edema means swelling. Atelectasis, as we talked about earlier, this is the failure of the lung to expand due to blockage of the bronchioles by secretions. We usually call this a collapsed lung. Okay. Pneumothorax, as we talked before, is an accumulation of air or gas in the pleural space, causing the lung to collapse. This can be caused by external mechanisms. So if you have a stab wound or a gunshot wound to the lung, you can have this. It also can be internal, such as lung disease relating rupture in the pleura. So if you have COPD and the lung just eventually is so beat up that it can't do it, it can do this as well. Pneumorrhagia, this is bleeding from the lungs, like I said kind of before with your hemoptysis. If you have bleeding from the lungs, the first concern is this tuberculosis related, because tuberculosis is very contagious and it can be an epidemic. Okay. One we kind of all know, pneumonia. We do not say the P. Okay, kind of like the other ones, pneumo and all that other stuff. I'm gonna sneeze. Inflammation of the lungs in which the air sacs fill with pus and other liquids. Okay, so pneumonia is mostly common causes or infection, often follows cold, flu, common cold, and chronic illnesses. Those with weak immune systems are too weak to fight the infection, so they are susceptible. If you go on to the next thing, you'll look and see that there are many different types of pneumonia. Okay. You have your bacterial pneumonia. This is caused by the bacteria Streptococcus pneumonia. You also have your pneumococcal pneumonia, which is the only form of pneumonia that we actually have a vaccination from. When you start seeing how many different pneumonias there are, you almost wonder if it's worth it. If you're immunosuppressant, like we talked kind of in the immune section, from things like an autoimmune disease, your medications, that so forth. Pneumonia shot is usually advised because the streptococcus or the pneumococcal is very hard on the body. Okay, so you have your viral pneumo. See, I keep calling it a pneumo. It's not a pneumo. Your viral pneumonia. This is caused by a disease. A third of the viruses are contracted this way. Okay. Then you have your lobar pneumonia. I have never personally seen this. This is affects one or more lobes of the lung. It's usually bacterial. It may just be that in the ER, I haven't seen it on the floor. I didn't get a lot of pneumonia patients, but in the ER, we diagnose them with pneumonia. We don't know what they are, what kind it is. We just know it's pneumonia. Okay. They have to have further testing to kind of find out which one, if it's needed to know. Bronchopneumonia, this begins in the bronchioles. It often leads to that lobar pneumonia. Okay. Double pneumonia, obviously it is what it sounds like. It's in both lobes. And then you have something called aspiration pneumonia. These are your older people, your people with tracheostomies, your people who have had a stroke. They don't eat normally. They have a hard time. This occurs when a foreign substance is inhaled into the lungs. This can be vomit. This can be food. This can be water. Okay. Aspiration literally means to inhale or draw in a foreign substance into the respiratory tract, and then withdraw by suction of fluids or gases from a body cavity. The reason they put on vomit is you hear about those people who get so drunk and they're at a party, these kids, and someone thought, they're dead drunk, let them sleep it off, and then they find them dead hours later. It's because they vomit, especially if they're on their back, and it aspirated into their lungs and it kills them, it suffocates them in a sense. You have your mycoplasma pneumonia. This is milder but long lasting. It actually comes from the I call it a bug, but the mycoplasma pneumonia. We call this walking pneumonia. Okay. So if you ever get told you have walking pneumonia, these are the ones that usually you feel terrible, you have a horrible cough, but you're able to function. It's just really slow. They call this walking pneumonia because you can get through it. You just feel like crap. The problem is it does last a lot longer than the other pneumonias. Then you have your pneumocystis carinii pneumonia. It's caused by a parasite named pneumocystis carinii. It frequently occurs with the weakened immune system, such as in HIV patients. This pneumonia tends to kill HIV patients because they can't fight it off because their immune systems are so weak. Okay. The next thing I want to talk about is not a PowerPoint, but it's tuberculosis. Okay, tuberculosis, you'll hear a lot of you guys get tested when you first get into your health programs, as well as when you first start a job, they test you for tuberculosis. This is an infectious disease that attacks the lungs. Okay, it causes pleurisy, hemoptysis, like we talked about, that spitting up of blood. It usually occurs in those with weakened immune systems. However, you can have tuberculosis and be called what's called latent. This is meaning it's not active. I myself have latent tuberculosis. I am what they call PPD positive, and PPD is the AKA name for tuberculin skin testing. Okay. What that is I have a positive result indicating the possibility of exposure, with further testing is required to see if active or not. So I can't take those normal TB tests anymore. I have to have a chest x-ray every year. Believe it or not, I've had it since I was about 8 or 9. My mom also has it, so we believe that the only places that me and her could have been that my brother and dad weren't was most likely the Children's Hospital, where I was being treated for many of my injuries or many of my illnesses when I was little. In the 80s, it was a little more apparent. We were less aware of how serious tuberculosis is. You don't hear about it quite as much now. Those who are around homeless have a greater chance of having tuberculosis because they don't tend to get treated. Okay, these are the patients that, if you have these patients and they recently got diagnosed with tuberculosis and they're on the medication, or they're getting started on the medication, they're in airborne isolation, so you wear a mask, gown, and everything else. Okay, and this is a special mask that you use. It's called an N95, because the regular masks can actually be penetrated by the tuberculosis infection. Okay. Next, we go on to something called pneumoconiosis. This is an abnormal condition caused by dust in the lungs that usually develop after years of environmental exposure. It's named for its causative agents. Now, we don't hear so much about pneumoconiosis, but we do hear about some of the agents that cause it. One of them is anthracosis. This is coal dust. Asbestos, okay. asbestos particles that we get from the mills. The firemen have been exposed to it for years because it was in things that we were burning, it was in our insulation, it was in some of the building products that they use in the past. So your older houses, there's a chance for when you sell your house, they have to check for asbestos. Okay. You have your bisonosis. This is your cotton, flax, and hemp dust. You don't hear so much about the cotton, flax, hemp. It was a big argument when the hemp necklaces and stuff like that came out. They started saying how it could be harmful to people. And then you have your siliconuses. This is your silicon dust and glass. So people who work with glass, they tell them to wear masks, especially if they're cutting it, because of this kind of thing. Okay. Earlier we talked about pulmonary, so in your word building it brings pulmonary up again, but what they're trying to hit on is the pulmonary fibrosis. Pulmonary fibrosis is the formation of scar tissue. Fibrosis means formulation of fibrous tissue. Okay, you see this with connective tissue diseases such as rheumatoid arthritis, scleroderma, and lupus, as well as you can see it with people who've been exposed to asbestos and silicone exposure. Okay, there are some that have pulmonary fibrosis that they don't actually know where it could come from because they don't have a cause. All right. So we're going to get past some of these disorders and we're going to kind of talk about breathing in general. Nursing students, I would listen up because this is going to be a lot of your assessments. You're going to look at this every single patient. So breathing, you have upina. I have to think about it because we don't use that one. Upina. This is easy or normal breathing. Eupnea. Okay. Then you have your tachypnea. This is abnormal rapid rate of respiration. This is respirations of 20 beats or greater per minute for adults. Children are always going to be a faster breather. Matter of fact, you'll have your infants are actually within 40 to 60 breaths per minute. You get those new mothers, they freak out because their kid's breathing fast. That is actually normal for them. But when it comes to an adult, you want them to be between 12 and 20. So if they're under 12, which is an abnormally slow rate, such as, or I should say under 10, that's called bradypnea. Okay. We learned in the cardiovascular section, bradycardic and tachycardic. This is the same concept. It's tachypnea and bradypnea, slower or faster and slower rates. Now you could have an apnea or apneic patient. These patients are absent of spontaneous respiration. Okay, these are the people who are not breathing for a certain amount of time. They need to either start back up or we need to assist them because anything too long can cause brain damage to the brain, as we were talking about earlier. So apnea is a common respiratory problem with premature infants. So they go through these little cycles, and babies don't breathe a regular rate. They breathe kind of funny, like they go, they're kind of fast, slow, pause, fast, slow, pause, because their bodies are different in a different way. Okay, they're respiratory driven, we're cardiac driven. Dyspnea, this is difficulty or labor of breathing. This is what we call our shortness of breath. Okay. Hypernypnea, this is an abnormal increase, but it's not just the rate, it's depth and rate. Okay, you commonly see this with exertion, exercise, that kind of thing. It also can occur at high altitudes or from someone who is anemic. If you remember a little bit, we talked about anemia. That's low red blood cells, or sepsis. And sepsis is your people who are septic or septicemia, who are extremely ill and their body is in some form of, is working towards a form of shock. Okay. Hyponipnia, if you noticed, hyponia, sorry. The second P is silent. This is shallow or slow respiration, so this is even worse than bradypnea. This is decreased depth and rate, so they're extremely shallow and extremely slow. Okay. Hyperventilation. These are your abnormally rapid deep breathers resulting in decreased levels of carbon dioxide. You know, these are the people they used to see that we used to give the brown bag to so they can breathe in. This is mental, not physical. It's usually associated with anxiety. It causes dizziness and tingling in the fingers and toes if they continue it, because you have a decreased level of CO2 in your body because you're breathing so fast, you're taking oxygen in, and you're blowing out the CO2 way too fast. We stopped using the brown bag in our ER because it looks very unprofessional. What we do is we put what we call a non-rebreather, and I'll show you, we'll talk about that later, a non-rebreather mask on your face, but we don't hook it to oxygen. So you're pretty much breathing in what you've spit out, okay? I don't think they have this one on the PowerPoint. It's sleep apnea. It is very important because with the increase in obesity these days and smoking and so forth, we're seeing a lot more sleep apnea. For the longest time, we felt like this was cardiac, but this is actually respiratory that leads to cardiac. And the reason is sleep apnea is a potential serious disorder in which breathing repeatedly stops and starts during sleep for periods long enough to cause a measurable decrease in oxygen levels. Okay. The problem with this is the first notable sign is snoring. My problem with us going out and saying that is that anybody who sleeps on their back who is in a good sleep can snore because the tongue is going to flap back. This is a first sign, but it does not mean because you snort you have sleep apnea. Sleep apnea is the reasons we have what they call sleep studies. One of the first things they test for you when you have something called insomnia where you cannot sleep at night is they make you do a sleep study. Both me and my husband did one. It is terrible. First of all, you go to the hospital where they have created what they believe is a bedroom, and it has, you know, a bed, and it has a TV. They also have a little camera in the corner because they watch you as you sleep. They make you come in the evening, just after dinner, and they go over a lot of questions with you. They watch you for an hour while you're awake of how you breathe. They put all these stickers all over your chest, all over your face, and then they want you to go to bed at like 8:30 and fall asleep as they watch your rhythms with all these stickers and cords on your head in a room that is not your house at a time that is not my bedtime, and you know that someone is watching. It was very hard for me to sleep. I did better than my husband. My husband was unable to sleep. They could not get his study to be conclusive of anything. They actually suggested it a second time, and he said absolutely not. I was found to see that I just have issues sleeping. It has no sleep apnea issues, but they also want you to lay on your back. I am a belly sleeper. I am side and belly sleeper, so sleeping on my back made it very difficult. If you ask a very large person, even bigger than myself, to do this, this can be very difficult. I have heard that they started doing sleep studies more in people's houses. So now you just have a stranger come to your house and set up a camera and hook you to all this stuff. But it still, to me, is a very complicated study that I'm not sure is always the rightest thing. Okay. If you are found to have sleep apnea, this is when you start seeing those masks that they show you, the CPAP masks, and we'll talk about those a little bit later. That's what sleep apnea, or that's what the CPAP helps with, is sleep apnea. Okay. So if you have a lack of oxygen, you have a few terms. We have anoxia. This is absence of or almost complete absence of oxygen. This is 4 to 6 minutes, could lead to irreversible brain death. So one of the things you learn in CPR, and CPR is very common anymore, they tell you one of the first things you need to do is start doing chest compressions to get that oxygen that's in your lungs into your brain. Okay, and then you do the breaths and so forth and so forth. The longer you're without CPR, the less likely you'll survive, because as they say, 4 to 6 minutes will lead to irreversible brain damage. And I believe that that is actually a very long time, 4 to 6 minutes. It's more like 2 to 3. Okay, kids are even less. Hypoxia, it is only one O. It's not hypoxia, it's hypoxia. This is a condition of having subnormal oxygen levels in your cells, less severe than anoxia. So we kind of talked about that in the beginning, but you're seeing it again. Cyanosis, okay. You guys last week in your cardiovascular were asked about cyanosis. This is the bluish discoloration of the skin caused by a lack of adequate oxygen. You see it in your fingertips and your lips first. If you have a person, I'm going to tell you right now, if you're in the medical field and you end up in ER surgery or something, there are times where you see blue people. These people have been without oxygen for a while. You get them oxygen right away, and they tend to pinken up a little bit if the changes are reversible at that time. If they're without oxygen for a long time, the likelihood of getting them back pink and warm and all that other stuff is very minimal. Okay. So along with the lack of oxygen, you can have what's called asphyxia. This is a pathologic change caused by the lack of oxygen. You see this in the anoxia and hypoxia states. Okay. Asphyxiation, this is interruption of breathing resulting in loss of consciousness or death. These are those people that are that die from suffocation. So if you have an interruption of breathing that's result in loss of consciousness, you're being suffocated. If you do not get oxygen in a short time, you will have respiratory failure, a condition in which the level of the oxygen in the blood becomes dangerously low. And if you don't have medical emergent care, death will be there, is near, and will not be reversible. Children tend to go into respiratory failure before they go into cardiac arrest, where adults tend to go into cardiac arrest. Okay, ours is cardiac driven, theirs is respiratory. So 9 times out of 10, it's respiratory failure. The kid's going first. Okay. Oxygen administration. So we kind of hit on a few of them as we went earlier. We're going to hit on again. So oxygen administration. Any healthcare individual, other than maybe my pharmacy techs, are going to see different types of oxygen. So you have your administered oxygen is administered by a compressor, either flowing into the hood or a tent, or delivered directly to the patient by a device. Okay, so what they mean by a hood or a tent is when babies are born and they're premature, you have those boxes. That's considered a hood. There are adult tents that are made for people who need oxygen. And then you have your devices for the patients. One is the nasal cannula. That's the 2-prong thing that goes in your nose. You see the thing going along their ears. That is a small tube that divides into 2 nasal prongs that gives a small amount of oxygen. These are your low dose amounts of oxygen that goes through your nose. So like 1 or 2 to 4, 3 or 4 sometimes 5 or 6 liters per minute. However, 5 or 6 liters per minute is pretty rough on the nostrils if you've never had it. Nasal cannulas can dry out the nose real fast, so when people are admitted to the hospital and they have to remain on a nasal cannula, they try to put humidified air, or they try to put humidified air to the nasal cannula, and how they do this is they add a water device to the oxygen supplier and it turns it into a humidified air. Okay. We have something called a rebreather mask. This allows the exhaled breathing to be partially used, delivering up to 60% of oxygen. So these are just the single masks, and they do not have many holes in them. They are not taking in a whole lot, but they expel out a one-way valve. So you breathe in the mask, and the one-way valve lets a little bit out, and that's it. Okay. Then you have your non-rebreather mask. This allows higher levels of oxygen to be added to the air taken in by a patient. These are the ones on the ambulance and in the ERs that have the bag that kind of hang from their face and they blow it up. This is because oxygen is just being pumped in and it's kind of collecting that CO2. Okay, you have an AMBU mask or bag valve mask. This is an emergency respirator used to assist ventilation. These are the ones they're bagging and they're holding that mask on, or they're giving mouth to mouth with a mask and a single valve. You have a CPAP and BiPAP machines. So as we were talking about with the sleep apnea, you have what's called a CPAP. It's a non-invasive ventilation device that provides continuous positive airway pressure, such as with sleep apnea patients needed by holding the airway open. Okay. CPAP you see on ambulances and you see in homes, where the BiPAP is what you see in the hospitals. BiPAP is a bi-level positive airway pressure with like a CPAP. However, it can be set at a higher pressure for inhaling and a lower pressure for exhaling. It is very hard for people when they first have to be put on a BiPAP because, first of all, it's a very large mask that is constantly blowing air into your face. When you're on these masks, you get very dry, and people don't like it because they can't eat or drink, because obviously if I take the mask off, let you have a drink, you put the mask back on, you can aspirate if it pushes you into the lungs too fast. BiPAP is not just used for respiratory issues. If you have a lot of pulmonary edema on your lungs, we'll put you on BiPAP to kind of push that fluid out of your lungs. Okay. And the last device is the ventilator. These are ones you don't ever want to see your loved member on. These are the mechanical devices that help with artificial respiration by forcing air to lungs. Exhalation takes place passively in the lungs by contraction. These are the people that we put the tube down their throat and we put the machine on them. Okay. Another one that they didn't really discuss is sudden infant death syndrome. I find this very important, especially just in the public. We've been teaching a lot of this. This is the sudden and unexplainable death of an apparently healthy sleeping infant. These are your 2 to 6 month old babies who mom and dad put down. There was nothing wrong when mom and dad put them down to sleep. They come in the morning. They're surprised the baby didn't wake them up to find the baby not breathing and having no heartbeat. There is such things as safe to sleep campaigns. They suggest you keep the baby on the backs, you have no blankets, pillows, or toys in the crib. However, there is really no reasoning that they have found truly with sudden infant death syndrome, or SIDS as they call it. However, they've noticed since we've started the safe to sleep campaigns that we are reducing the incidence of SIDS. This does happen in the colder months. However, I will tell you, I have already seen 2 this year, and I work part-time. Okay, so it does happen. It is very tragic because as a healthcare worker, we do everything we can, and you work this baby for for an hour, sometimes two, because babies you can work them that long to have the same result you knew the minute that baby came in, that you're not going to get this baby back because this baby has been dead for a little while. Okay, keep in mind sometimes resuscitation is done for the family, even if the patient, even if the healthcare workers don't believe that the care is going to help the patient. Sometimes families have to see that happen. Respiratory rate and respiratory sounds. Respiratory rate is an important vital sign. It's the count of number of breaths. So you have your one inhalation and one exhalation as a breath, okay? But with your respiratory sounds, the sounds provide information about the condition of the lungs and the pleura. You'll have things such as rales, bronchi, stridor, you'll have diminished sounds, and then you're going to have your clear sounds, okay? You will note it bilaterally, so you'll note it on the left, you'll note it on the right, note it on the upper lobes and the lower lobes, okay? Back to our PowerPoint, you have your diagnostic procedures. You have your bronchioscope. This is a visual examination of the bronchi. The instrument used is a bronchoscope. The right bronchi is more direct path. It's commonplace for foreign objects. You can actually get a bronchoscope in the doctor's office or the ENT's office. It was terrible. They spray this stuff down your nose to numb it. And it numbs all the way down your throat and even kind of your gag reflex, and that's the point, so that they can take this thing and kind of push it down your nose. You don't choke, you do feel it. The numbness to me was worse than the actual instrument, and that's because I felt like I couldn't stop spit from going down my throat. Laryngoscopy, this is a visual examination of the larynx. We use a laryngoscope for this. However, we also use a laryngoscope, which is also visual examination, when we do what's called endotracheal intubation. EMS and ER and ICU patients are able to have this done. This is where they stick that tube down your throat to help you breathe. It's called an ETT tube. Which is the passage of a tube through the mouth into the trachea to establish or maintain an airway, such as with a patient on a ventilator or to help assist with breathing. What they do is those vocal cords, they see the vocal cords and they go right between them and they get it right into the trachea. So they use this scope to visually examine where they're going to put it. We have actually got more advanced. We have cameras that we use. We have fiber optic cameras we can use. We have glidoscope cameras. So that some of these difficult airways, such as in little kids or very large people or people with trauma, we can actually have a little bit of a better idea of where we're going. Okay. Diagnostic procedures, they also have your magnetic resonance imaging. This is used to see the soft tissue structures such as joints. It's less effective on bones. The reason this is important in the airway also is because we use this a lot for clots that are seen in the lung. Okay. We talked about the sleep study earlier. That is actually called a polysomnography. I like to just say sleep study. Okay. Go on. We have treatment of nose and throat. So you have your word building rhinoplasty. This is a surgical reconstruction of the nose. This is cosmetic surgery to change the appearance of the nose. This is also done for those who have septums that are not quite straight. They're more jagged or they go over one side. When we as nurses have to do things like put a tube in your nose to go to your stomach, we look to see which nostril's bigger. Mine are very equal. If you look at my husband's, he has a larger nostril than the other, so I would definitely pick the larger. However, keep in mind your right nostril is 9 times out of 10 your larger nostril, so we go for the right. Septoplasty, as I was talking, this is the surgical reconstruction of that septum so that you can breathe. Some people get polyps and stuff, and it just clogs it, and then you have your septum that's pushing on top of it. It's all jacked up, so they get it redone. Sinusotomy, my mother had this. This was a surgical incision into the sinuses. They did this to clean out her sinuses. She looks like someone beat the crap out of her the day later. She had her eyes swollen and everything else. People who have extreme allergy issues, they'll look into the sinuses. This is to help the sinuses. Sometimes it works, sometimes it doesn't. Pharyngeoplasty, surgical repair of the pharynx. Pharyngenostomy, this is a surgical creation of an artificial opening into the pharynx. We call these stomas. Okay. Pharyngiotomy, this is a surgical incision of the pharynx. Laryngectomy, this is surgical removal of the larynx, usually for surgeries. Then you have your laryngoplasty, that's your surgical repair of larynx. Okay. Onto the trachea and bronchi, you have your tracheoplasty. This is a surgical repair of a trachea. I think we see this more in trauma and surgery and cancer. Okay. Tracheorrhaphy, this is suturing of the trachea. Tracheotomy, this is the surgical incision into a trachea. And then you have your tracheostomy. These are your surgical creation of artificial openings in the trachea. Those are those circles that people breathe through. Okay, and these are called stomas as well, and that means an opening in the body surface. We're finishing up, you guys. We're close to the end. Treatment of lungs, pleura, and thorax. Pneumonectomy is a surgical removal of all or part of a lung. I will tell you this is on your assignment. This was the hardest one to find, so keep that in mind. Lobectomy, this is a surgical removal of a lobe of the lung. This term is used to describe the removal of a lobe of the liver, brain, and thyroid as well. You see lobectomies, like people have cancer in a certain lobe, they'll try to remove it. I had a friend who had this, they just removed the bottom of his right lobe. Pleurectomy, this is a surgical removal of part of the pleura. So they literally take a layer that's surrounding your lung off. Okay. Thoracentesis, this is the surgical puncture of the chest wall to remove fluid or air from the chest cavity. On your PowerPoint, you have a very disgusting picture. However, that is pretty much what it's like. Okay. Thoraectomy, surgical incision into the chest wall. This is where we try to remove your pus or foreign object. Usually you see this more when we're trying to put in a chest tube. We might do this to try to remove a bullet if we see it right there. And then you have your thoracostomy. We do these in the ER. These are surgical creations of the opening into the chest. This, we can remove pus, blood, air. We usually have to put a chest tube in if we're going to do that. But they also will do them sometimes in surgery and then plug them up. Okay. Last but not least, we're going to go over some abbreviations. They have the three, the RT, which is a respiratory therapist. We do call that in the hospital. COPD, chronic obstructive pulmonary disease, as we've talked to you before. You usually will hear COPD versus the full say. URI, upper respiratory infection, which means there is also an LRI, lower respiratory infection. I will tell you most of the time you see upper or URI, and they usually write out lower. Other ones you should probably know is, like I said, upper respiratory infection. Oh, I meant to put lower and I put upper. TB, tuberculosis, okay. RF, respiratory failure. However, keep in mind, we do confuse this with renal failure in the hospital. Usually renal failure is either ARF or CRF, meaning acute renal failure or chronic renal failure. Okay, and last but not least, as we talked before, SIDS, SIDS, the sudden infant death syndrome. And that is the end of this respiratory section and lecture. We're just over an hour. You have a crossword puzzle as well as, I think it was like a case study you have to do. You have your pre-test, you have your quiz, and then your chapter learning exercise quiz. Make sure you get them done. They are due next Wednesday. Obviously, none of your homework for this week is due till Friday. Do not wait on it. Get it done. This is a very important chapter. This chapter, as well as cardiac, will be definitely on the final. So make sure you take the time and truly listen. Nursing students, EMT students, respiratory and cardiac are very important for your things because no matter what field you're in, these are parts that you need to do. I hope you guys did well in your midterm. Obviously, most of you who will get this lecture will get it after the midterm. I'm actually going to be leaving in a little while to come take your midterm with you guys. So I will see you next week. Have a good weekend, and thanks for taking the time to see the lecture.